Good morning. Today's topic is about principles of surgery. Coming to the principles, it's common for all surgeries, not only just maxillofacial surgery, but for all other surgeries like medical on the medical field itself, not just dental surgery. So we have 10 basic principles. The first one is developing of surgical diagnosis. The second is basic necessities for the surgery. Third is aseptic technique. Fourth is incision. Fifth is flap design. Sixth is tissue handling. Seven is hemostasis. Eight is decontamination and debridement. The ninth one is edema control. And the 10th is the patient general health and nutrition. Right now, we are going to start discussing about each of these 10 principles. First one being the developing of the surgical diagnosis. The decision to perform surgery should be based on a cumulative surgical several diagnostic tests, not just the patient history, but also their medical history. You'll have to ask about the oral examination and other TMJ as well as the lymph node palpations, and you have to take radiograph. Based on all these, not just the investigations, but also the clinical history that we take, and also the examination that we do. Based on it is what we derive with the surgical diagnosis. Only with these surgical diagnosis can we do a perfect treatment plan. So the first step is the initial step in the surgical evaluation is the collection of accurate and pertinent data. This is accomplished through the patient interviews, physical, laboratory, and imaging examination, and the use of consultations. Developing surgical diagnosis is also a clinician's knowledge. It's totally based on clinician's knowledge. So clinicians should also must be a thoughtful observer. Like we say, when the patient just walks into the clinic, we have to start analyzing the patient, especially with their gait, how are they, how whether they are obese, whether they are well nourished, whether they are underweight. All this leads to the surgical diagnosis. Whenever a procedure is performed, they should know that all aspects of its outcome to advance their surgical knowledge and to improve future surgical results. Coming to the second principle of surgery, that is basic necessities for surgery. Coming to basic necessities, there are two types. First one is adequate visibility. In that, you need adequate access and adequate light. And then is the surgical field free of excess blood and other fluids. Coming to adequate access, especially in the maxillary third molar, and when the patient is chubby or like overweight, the cheeks tend to go into the onto the maxillary third molar, and the access is bit less. And here we have to sit and do both our handpiece, our mouth mirrors, our retraction, the suction. Everything comes together while we do a impassion of the maxillary third molar. So access is a very important thing. On top of that, we need adequate light, especially when the person who is assisting should not block the light that is coming from the light source. Then the surgical field must be free of excess blood fluids and other fluids. Second one is assistance. A surgeon's success is also depend on the effectiveness or the efficiency of your assistant. If the assistant is bad, the surgery tends to go bad because surgeon has a difficulty in managing the surgical field. Coming to aseptic techniques. In aseptic techniques starts from when you start wearing your gown. The gown is usually washed and autoclaved, especially when you go for major surgical techniques where you go into the operation theater. And also, you have to have a adequate hand washing as well as scrubbing techniques should be done properly. And draping of the patient is also very important in coming to surgical techniques, especially in maxillofacial area when there are two or more surgeries that is done, especially when there is a head injury. Usually the neurologist do first and then comes to oral and maxillofacial surgery because our mouth contains a lot of microbes in it. So first, always they prefer an orthopedician or a neurosurgeon to do their treatment first, and then last comes maxillofacial surgery. So this is basically to make sure that there is no cross contamination. Coming to incision, your incision is a major plays a major role on how well of an access you get to your bone or the teeth or the place wherever you're, especially in fracture and all, your incision must be perfect. So this was an extraoral incision that is placed below the lower border of your mandible. In incision, you have principle. The first principle coming be the sharp blade of a proper size. The blade should be sharp and it must be of the proper size. In an intraoral incision, we use 15 number blade. Coming to the second principle, it should be a firm, continuous stroke is used while incising. You should not repeatedly place the incision over and over again. The third one is the surgeon should be careful to avoid vital structures when incising, especially arteries. And coming to the fourth principle, the incision through the epithelial surface that the surgeon plans to reapproximate should be made with blade held perpendicular to the epithelial surface. Fifth principle, it is more desirable to incise through the attached gingiva and over healthy bone than through an unattached gingiva or over the unhealthy bone or missing bone. Coming to flap. Flap is basically once you incise, you retract your soft tissue is known as flap. In coming to intraorally, you have the mucosal flap as well as the mucoperiosteal flap. Surgical flaps are made to gain surgical access to an area or to move tissues from one place to another. And how to prevent flap necrosis? It's basically based on how much of the width of the flap is and how much is the height of the flap. At least the width of the flap should always be twice the height of the flap. So how to prevent flap necrosis? First one is wide base, then sides should be parallel or preferably converging, moving from the base to the apex. Length should be no more than the twice the width of your base. And axial blood flow should be included in the base of the flap. And the base of the flap should not be excessively twisted or stretched or grasped with anything to make sure that there is no damage to the blood vessels. Then margin dehiscence, how do you prevent it is by approximating the edges of the flap over the healthy bone or by gently handling the flap edges and by not placing the flap under tension. Then another thing that new surgeons do is flap tear. When you try to hold with your toothed forceps, you tend to tear the flap and thereby interrupting the closure of your flap. Now, this is an extraoral flap that is held near the submental region. Tissue handling. The difference between an acceptable and excellent surgical outcome often rests on how well the surgeon handles the tissue. Actually, the soft tissue, if you handle it very well, you tend to get a greater wound healing, much better wound healing. When your tissue handling is very aggressive, you tend to have a traumatic ulcer, and thereby the patient will suffer unwanted ulcers as well as painful experience during the wound healing process. Excessive pulling or crushing, the extremes of or extreme temperature, desiccation, or use of unphysiological chemical easily can damage the tissue. Tissue forceps should not be pinched too tightly. Tissue should not be overly aggressively retracted to gain greater surgical access. Coming to hemostasis. What is hemostasis? Is basically the arresting of bleeding, and that is done by the vasoconstriction of your blood vessel. How do you attain hemostasis? The first thing that you do is to prevent excessive blood loss is applying firm pressure. Another thing that we can do is adding adrenaline to your cotton and then pressing over it, because adrenaline causes a vasoconstriction, thereby reducing the blood loss. You can also use, when there is excessive bleeding, you can use ab gels or bone wax if the bleeding is from the bone. If it is from the vessel, then you can do a suturing of your vessel also. Means to promoting wound hemostasis is, first one is natural hemostatic mechanism. Second one is thermal coagulation, that is through cautery. Then fourth one is suture ligation, especially in the blood vessel. Then pressure dressing over the wound. And fifth one is placing vasoconstrictor substance, like I said, adrenaline. So this is where the bipolar cautery is used. If you can see, there is a vessel over here, and they are cauterizing the minor blood vessels. Okay, this is they are cauterizing the minor blood vessels. Dead space management. Dead space management. What is a dead space? That's what first we have to know. Dead space in a wound is any area that remains devoid of tissues and closure of wounds. Dead space is created by removing the tissue in the depths of your wound and not reapproximating all the tissues while laying during closure. In intraorally, most of our suturings are one layer, except for the chin region, where you will have to do two-layer closure. That is, the first one is your deeper layer is your mentalis muscle, and uh, the superficial layer is your oral mucosa. So most of your intraoral is usually intraoral, mostly it is usually one layer closure. But when you go to extraorally, especially over your TMG or your temporal region that you're going, you need to do layer by layer closure. And mostly the inner layers are usually closed using resorbable sutures. And outer layer is usually done by non-resorbable sutures, where you can remove after 7 to 10 days, and alternative sutures are first, and then you progressively. But you should make sure that the suturings are done layer by layer. Another way you can make sure that space is managed is by pressure cuts that you put, or you also use drains, surgical drains, where in these between the layers, when there is fluid collection or a blood collections, you can use drains, thereby causing the management of your dead space. Dead space in a wound usually fills with blood, which creates a hematoma, and which is with a high potential for infection. How to eliminate dead space? Suturing of planes together to minimize the post-operative void. to place a pressure dressing over the repaired wound, to place packing into the void until the bleeding has stopped, and then you remove the packing and use of surgical drains. This is what I've said before. This is a surgical drain that you have seen. The next principle is decontamination and debridement. Repeated irrigating of the wound during surgery is a must, and closure. Closure should be done. The irrigation can be achieved by forcing large volumes of fluid. Usually, what we do is the fluid that we use is normal saline under the pressure on the wound. Wound debridement is the careful removal of from the injured tissue of the necrotic, foreign, or severely ischemic material. Edema control. Edema control occurs after the surgery as a result of tissue injury. Edema is the accumulation of fluid in the interstitial spaces between your tissues or your cells because of transudate from the damaged vessels and lymphatic obstructions by pipe. Greater the amount of tissue injury, greater is your amount of edema. Usually after surgery, the edema is more. Especially if you see the difference in impaction, surgically extracted tooth and normal extractions, you will see after 1 day the patient will have severe edema or swelling. The more the loose connective tissue that is contained in the injured region, more the edema is present. How to reduce your post-surgical edema? First one, perform the surgery in a manner that minimizes your tissue damage. Second is ice pack application. Third, patient position. That is, if you see the surgeons ask the patient, or in the ICU also, you can ask the patient to keep their head elevated from the rest of the body as much as possible for the first few operative days. Then you can give high dose of systemic corticosteroids can be administered into the patients. Corticosteroids are useful for edema control only if the administration is begun before the tissue is damaged. Last principles of surgery is patient's general health and nutrition. Proper wound healing depends on a patient's ability to resist infection, to provide essential nutrition for use as building materials, and to carry out reparative cellular process. So basically, patients usually, especially in patients that goes to OT treatment, OT or operation theater for a major surgery, they are usually in nil by mouth or nil by uh, oral, that is MDM or MPO. That is, patient is not even had any fluid or any water or food for 4 to 6 hours, or sometimes it can extend to 8 hours. For that, all these fluids should be replaced during the operation theater and post-operative. So those nutritions are essential, and especially in maxillofacial surgery, the patient has undergone trauma and he's on IMF, and patient can't eat any solid food, and it is usually liquid foods that. So make sure that the patient is on constant surveillance of to make sure that there is proper nutrition given. Okay, or you can replace it by IV fluids. Numerous medical conditions impair a patient's ability to resist infections and heal wounds. Diseases that induces catabolic state is poorly controlled diabetes mellitus, end-stage renal or hepatic diseases, and malignant diseases. Conditions that interfere the delivery of oxygen and nutrition to wounded tissue is severe chronic obstructive pulmonary disease, poorly compensated congestive heart failure, and ethanols. Diseases require the administration of drugs that interfere the host defenses or wound healing capacities, such as autoimmune diseases, malignancies for which toxic agents and irradiations are used. Thank you.